and have one. I throw it to you.
Got it.
You can start whenever you're ready.
All right. Hi, everyone. Thank you so much for joining us today in our session. We're excited to have you all here today. We're going to start off with some brief intro information, and then I'll introduce you all to our professional. We're so excited to have Dr. Margaret Adam here with us today and excited to get into this session. So I'll share my screen and we'll get started. All right. Hopefully we're all good there. Looks good?
We're still seeing the out view, not the intro.
Oh,
I don't know why. For whatever reason.
for whatever reason that's happening now. Um,
I would just try
Content.
escaping and then clicking share and then reopening it.
Okay. Take two.
Love it. And we still have stragglers.
Now my computer's freezing, of course.
Do you want me to start it up?
Let me try one more time and see if it'll let me do full screen.
Tech is always great and awful at the same time.
Right. Cool.
Oh, yep. Works perfect.
All right, there we go. Thank you, everybody. Well, welcome to our session. Thank you for joining Pre-Health Shadowing. We are an international student-led nonprofit for medical advancement. So the goal here is to give folks the opportunity to meet some people that are involved in the healthcare system and hopefully learn more about the different opportunities to be a part of the healthcare system. So we thank you all for being here today. So for this session, we do have closed captions available, but our goal is always to make them even more accessible. So if you have any ideas about how we can do that, feel free to email us at info@prehealthshadowing.com. Just in general, that's a great email to have because that's how you can get more information about pre-health shadowing. So if you have any questions or want to get involved, that would be the email to use. Be sure to save us as a contact as well. Make sure that we stay out of that spam. And also, if you join the email list, you will not miss any upcoming sessions. All right. So in addition to our email, we also have some social media platforms that we'd love to engage with you all on. We have Instagram, TikTok, X. I still call it Twitter, so I'm going to refer to it as Twitter. And we also have a YouTube channel that we use to post all the sessions as well as a LinkedIn. So please feel free to connect with us on all of those social. We love to post and talk to people who are interested and share opportunities that come up. All right, hopefully we'll get some engagement from all of you. We like to start off all of our sessions by asking where folks are joining from. So please feel free to pop that in the chat. Where is everyone Zooming from right now? I am currently in Davis, California. Any folks in NorCal? Arizona, Iowa, LA. I'm from Southern California originally. Dallas, Texas, Colorado, Virginia. Nice. All right. Well, hopefully y'all can connect with some people if you're from the same state. And we are excited that you all decided to join us today. I know we have a variety of time zones in the house, so sometimes coordinating that can be a little tricky. So we appreciate the time. If you are interested in being a part of the pre-health shadowing team, we have some amazing volunteer opportunities that are listed on the website. And you can also email, like I stated at the beginning of the session, if you're interested or have any questions about how to get more involved. It's a great opportunity to learn more, as well as kind of flex a new muscle, maybe get some professional development under your belt. If you are 1,000% interested and you're like, I really am gung-ho about being a part of this, but I think I want to do a little bit more. I have a little bit more time to spend with pre-health shadowing. I would definitely recommend y'all joining our leadership team. We have a list of positions that are available on the pre-health shadowing website. It is 100% remote, so you can do it from anywhere and join our team to make sessions like this and create other opportunities for folks who are aspiring healthcare professionals. Like I said, the applications are listed on the website, and we have a variety of roles that are currently available. If you see any gaps in the roles that we have available, we are also super open to opening up any new positions that y'all would like to see on the pre-health shadowing team. So please let us know if any of those come up. All right. If we have any high school students in the house, thank you for joining us today. And we also offer some leadership programs that you can bring to your high school. Pre-health shadowing is really passionate about bringing the work we do to our communities and getting community members involved. So a great way to do this would be for you to bring a pre-health shadowing team to your high school. So if you have any friends who are also interested in healthcare, you can let us know and start a club for pre-health shadowing on your high school campus. We also ask that if you are at all able to donate, please do. This program is solely run by time and donations of the volunteers, so it's really important that we support everybody who's involved in making pre-health shadowing great. So if you can donate, we suggest that you do. However, we know that some are unable to, and that's completely okay because you can also donate your time with some of the volunteer experiences. Another great opportunity to get involved is to send this QR code or the link to anybody in your network that is interested in supporting the health professions team or folks that are aspiring healthcare professionals. So that will also be available on the website. We hope that this will be an interactive session. I know Dr. Adam was saying how excited that she is to talk to y'all. So please type your questions in the chat. We have some folks that are monitoring the chat that will be able to ask your questions out loud, but you can also interact in any way that you see fit or feel comfortable doing. So we'd love to hear your voices, and we will also have some time at the end of Dr. Adams' presentation for a dedicated Q&A. So excited for that. Please take notes during the presentation that we're sharing or anything that Dr. Adam is talking about. There will be a post-shadowing assessment that will be available so that you can earn your digital certificate. So make sure that you're taking notes. Also, if you have anything that you want to look up after the session, it's great to have a reference for anything Dr. Adams will be sharing so that you can kind of do your own research on the back end. And lastly, we ask that you all turn your cameras on if you can and are in a position to. As much face-to-face as possible is great in this kind of Zoom universe. We don't really get that sometimes, so we would love to see some faces. And it'll just be fun. You can put like a face to the name. So please do turn on your cameras if you can. That's all that I have. I'm going to toss it to Dr. Oh, we got a camera on. Yeah. Cheers for you. Thank you so much. We love seeing y'all. And I'm going to toss it to Dr. Adam to begin our presentation.
Okay. Well, thank you very much. And thank you for inviting me to be here. So I am, let me get this out of the way there. So I am a clinical geneticist, and many of you may not know what that is, and that's one of the things I'm going to talk with you about today. So what I am actually a medical doctor, and I do see patients who have genetic conditions. So how did I get interested in doing something like this? It was not a typical road necessarily. I think that in the field of genetics, there is a misconception that if you want to do something in genetics, you really have to be a basic science researcher who's working in a lab. And that certainly is one pathway that people can be involved in something like genetics. But that wasn't really what I wanted to do. So when I went to undergraduate, I definitely was interested in being pre-med. And I did work in a genetics lab. And what I saw were people who did basic science genetics research, which was fine. I was fortunate enough to actually be in a lab where the person I worked for in the early 1990s was actually doing direct genetic research on humans, meaning that they were trying to find genes that lead to human genetic disorders. And what that meant is we actually were going into the clinics and taking samples from patients and doing genetic testing in a basic science research lab. Now, there isn't as much of that today because we have learned so much about the human genome over time, and many genetic conditions are being described not through that mechanism anymore. Not that you can't study human genetic diseases in a lab, you absolutely can. It's just that we aren't usually going into clinics trying to find genes in people who have a known clinical diagnosis. It's a little bit different these days. And so what I learned from that is I did not want to do basic science research for the rest of my life. Now, some people do, and that can be a great avenue. There's lots of opportunities in basic science to actually use genetic techniques to study lots of different things. But that's not really what I wanted. What I looked forward to was actually going in and seeing patients who had genetic conditions. But again, my perception was that's not a viable long-term career prospect if you're interested in going into medicine and you want to see patients. And it turns out that is absolutely not true. It's just not well advertised, shall I say. And so when I went to medical school, I actually looked around at a lot of different things. And for those of you who are interested in going into a medical field where you're going to be interacting with patients, do keep an open mind, because you never know exactly what you're going to like. And for me, because I grew up in the 1980s, you can see how old I am, there was, again, this idea that if you were a woman who was interested in medicine, you were either going to do pediatrics or OBGYN. And so my first thought is like, I'm absolutely not doing either of those fields because that's what everybody thinks I'm going to do, and I'm going to show them that's all wrong. And then it turned out that actually wasn't true. So when I went into medical school, I actually looked at some surgical subspecialties, decided that was not for me, ended up doing lots of different rotations as a medical student, and realized that actually what I did enjoy was pediatrics. And within that, I actually found several mentors in pediatric genetics who do primarily patient care. So the one thing that is more challenging if you're going to go into a subspecialty that is not as common, maybe rarer number of individuals with certain genetic conditions, it also meant that I ended up having to go into academic medicine, which is a little bit different than private practice. And there are very limited opportunities for clinical genetics within private practice. So sometimes decisions that you make will restrict what your career opportunities are. Actually, for me, that wasn't necessarily a problem, but to work in academic medicine, you pretty much do have to be affiliated with some type of either research institute, medical school, or academic medical center, which is usually centered with a university. So I actually started my career as an assistant professor at Emory University in Atlanta as a clinical geneticist. And working there, I saw patients 80% of the time. And then I did 20% clinical research. So most academic positions require you to do some form of research, but it doesn't have to be basic science research, and teaching. Which again, I enjoyed teaching anyway. So you are usually at an academic medical center, you're doing teaching, you're seeing patients, you're working with medical students, you're working with residents, you're working with fellows, you're working with other faculty members. And then after I spent 5 years at Emory, I came to the University of Washington, where I actually work in Seattle Children's Hospital. I'm actually inside Seattle Children's Hospital right now. This is my office, which is inside the hospital. A lot of places actually don't have offices inside the hospital. This is relatively unique to Seattle Children's Hospital at the moment. But but what I realized is that if you do go into academic medicine, there are definitely trade-offs. Again, you can't work anywhere you want, but you also get to do a lot of other really fun things. So my current breakdown is I see patients 50% of the time. I am a medical editor 30% of the time, and I do 20% research. And my research has taken me all over the world, including to South Africa. For clinical research studies, I work with several other universities doing collaborative research studies, studying whether certain medication exposures during pregnancy can lead to adverse outcomes for infants, particularly birth defects or other problems. So that's a brief walk through what I did. If you are interested in something like genetics, you don't have to go into pediatrics. There is adult genetics, there's genetics in OB, there's genetics in oncology. Genetics really touches many fields of healthcare. I'm going to talk about that in a second, but I was going to say, however, if you are somebody who potentially is interested in genetics, but you are not interested in going to medical school, another option, which again, a lot of people don't necessarily know about, is to go into a genetic counseling program. So what is the difference between a medical geneticist and a genetic counselor? So a medical geneticist like me, I'm somebody who went to medical school. I did a pediatric residency. I did a medical genetics fellowship, and I manage patients with genetic conditions as well as diagnosing patients. So I, do diagnostics, I do management, kind of those things. However, as you may know, genetics can be more complicated. There's a lot of issues around inheritance, genetic testing, etc. And so we work closely with genetic counselors. Most patients that I see, I also see with a genetic counselor, so we work hand in hand. Genetic counselors are individuals who have a master's of genetic counseling. So after undergraduate, they go into a master's of genetic counseling program. We do have one here at the University of Washington. There are multiple programs around the country. And what you do is you learn specifically information about genetic conditions as well as inheritance patterns, and you do the actual counseling of families. So talking with families about what this genetic condition might mean for them in the context of their family, of kind of their greater community, what resources are available for them, what are recurrence risks, how would we test for that, that all of that information. So it is a profession where you get to see patients. Frequently, you're seeing your own patients. You may be also interfacing with a medical geneticist or clinical geneticist. And then there's also opportunities to work in an academic medical center, in a private practice office, primarily that is usually either in cancer genetics, working with an oncologist for people who have cancer predisposition syndrome, or in an OB or maternal fetal medicine office with prenatal patients where there might be a concern about a genetic condition in a prenatal setting, or again, you can work in pediatrics. So there's lots of different opportunities. You can also work for a clinical genetic testing lab. So helping them get their results out, helping them write genetic testing reports that are going to go to patients and families, and providing that kind of genetic counseling. So just want to point out that there are ways that in anyone who's interested in genetics who doesn't want to go to medical school to still be able to have direct patient care in a setting that isn't just a basic science research lab, which is also another opportunity. And then also within the field of genetics, you can actually get a PhD and you can become a lab director working for a hospital lab where you're actually doing genetic testing. You're doing the testing in the lab. It's not research per se, but someone orders a genetic test, you're running the lab, you're interpreting the results, you're giving it back to a clinician. So again, lots of different things I think that many people have not been introduced to or don't know that that's even an option or something you can do. So we do have people who do a basic science PhD and decide, I don't really want to get my own grant support and run an independent research lab. I really want to, run genetic testing assays in a lab and provide results to clinicians who are using it in direct patient care. And so there is demand for that. There are also private genetic testing labs, including direct-to-consumer labs and other, commercial labs that we use that are outside of an academic medical center. So again, brief walk through field of genetics, because that's what I do. But I do also want to introduce you to the concept of, what if I went into a healthcare field and I came across somebody with a genetic condition? I don't know what it is. Where can I look for information about that? And I wanted to introduce you to a freely available online resource for genetic conditions that is NIH funded and posted on the NIH National Library of Medicine website. So I'm going to share my screen here, and hopefully it will actually come up. Okay, can you guys see the Gene Reviews website? Yes?
Yep, we can.
Okay. So I'm actually the editor-in-chief. I'm going to move this because just for whatever reason from my screen there. I'm the editor-in-chief of Gene Reviews. That's one of my, what I mentioned, I do medical editing 30% of the time. So 30% of my salary is funded by the NIH to actually provide content with my co-editors. We have a whole project called Gene Reviews that is a healthcare resource for, although families can use it, it is really written for a medical professional. And we, as you can see from our homepage, currently have 928 chapters on different genetic conditions that you might come across and you don't know anything about, and I want to know what this is, and can you give me the quick and dirty about what this means? I'm about to walk into a patient's office, a patient room, and I don't know what this means. So if you go down here, actually I'm going to go ahead and just search. So let's say I'm seeing a patient with Kabuki syndrome. Okay, what is that? I don't even know what that is. Okay, so here we go. This is what a gene, did it change? So it's a Gene Reviews chapter.
No, I was
No.
trying to say your screen's not up anymore.
Okay, let me just try it again. Share. Okay, what are you guys seeing a chapter that says Kabuki syndrome at the top? Okay, so right here, is this a point? Can you see this pointer? Okay, there's a summary section at the very top. It tells you what it is, how do I test for it, what are the management issues, what's the genetic counseling. This is a quick and dirty summary. But then it goes through all of these different components. And you can see on the sidebar here, let's say I don't know what to do for a patient. I'm seeing this patient for the first time. What do I do? You can scroll all the way down, or you can go to this here, management. Here's what you need to do. Like, it's like a checklist. Do this, do this, do this, do this, do this for this patient. So again, over 900 chapters on conditions like this. Now, it also goes through management, treatment of manifestation. What do I do about that? And then it goes through surveillance. Well, I've seen them before, but what do I do next time? So this is freely available. You don't have to have a subscription. Anybody can use it. This is a resource that is offered by the NIH for this. And I have to say that there's also a bit of a misconception that if you have a genetic condition, the only treatment is gene therapy. And that also is not true. So a lot of what we do is truly supportive therapy. You figure out what problems somebody has and you treat those problems. Do you have to have a known diagnosis to know that? Not necessarily. But so a lot of people say, well, you don't really do things like I want to, be interventionalist. And there are ways that you can be interventionalist as a geneticist, particularly if you're looking at inborn errors of metabolism. But let's look up CA. Let me just pull this up. Sorry. Before I share my screen. Okay, so, but it turns out that over time, what we have learned is that we can take drugs, many of which are already on the market, and we can repurpose them to help with genetic conditions if we understand the underlying molecular basis. Why does somebody have, like, what's causing the symptoms in this person? And can we use a medication to impact that, as opposed to can we change their genetic underpinning, which is very difficult to do. So let me just show you, because this is also in Gene Reviews. Okay, I got to share my screen. Okay, so what you're going to be seeing is for a condition called PIK3CA-related overgrowth syndrome. So this actually covers a whole host of different symptoms, but within a gene reviews chapter, we also have something called targeted therapy. Like, is there some drug you could use for this? And there is. So there actually is a drug that can decrease the overgrowth in this condition by targeting the molecular pathway that causes this condition and shutting it down. So our website does include information on gene therapy, molecular therapies, other prescription drug medication therapies, things like that. It also has a whole section just on genetic counseling. If you're like, I saw this family, what's the mode of inheritance? How do I counsel a family about this? That's all in there. And like I said, so if you are if you are going into a healthcare profession and you come across someone with a genetic condition and you don't know what to do, go to Gene Reviews first. This is not a plug for me because this is not a commercial product. But a lot of people are not aware that this is available and is a resource that you can go to that's trusted. These are all written by experts on a specific genetic condition. They have to have there has to be someone who's published on the condition, is actively seeing patients with the condition. Generally, it's the person who's recognized around the world as being an expert on this condition. And so it gives you an idea of like what this person says. I've seen a lot of people with this condition. This is what I would do. You can also email. We have email addresses for every author. You can email an author and say, I've got a patient with this. I don't know what to do. Can you help me? I am personally a Gene Reviews author on 2 different chapters for conditions that I'm considered an expert on, and I'm always happy to help whoever contacts me, including families, will contact me directly and say, I'm having an issue, like, can you help me? Because of medical licensing issues in the United States, I have a medical license to practice in Washington. I cannot provide direct medical advice to people who aren't in Washington. What I can do is I can actually advise their healthcare provider on what to do. So I can't do direct patient care for someone who's not in the state of Washington, but you can talk with any other healthcare professional around the world and you can give them advice on what you would do for this patient. So the other thing I want to introduce to you, which people may or may not know, is, as many of you know, we're, of course, moving into a world of artificial intelligence. And how is that going to impact medicine? I think that we don't know how it's going to impact medicine yet. But in terms of if you are a healthcare professional and you have a question, a healthcare question, doesn't have to be genetic, can be anything, and you want a usable summary of what is this, can I find out? There are lots of places you could go. However, some of them have limited information, have not correct information, etc. So another project that I have worked on, and I will disclose, I am on their medical advisory board, but it was only after I used their product and gave them feedback about how I thought that they needed to change it in a whole bunch of different ways that they said, would you be on our medical advisory board? So this is, let me just make sure, are you guys seeing open evidence? Okay, so open evidence is an AI query that actually, as you said, as you can see here, has content agreements with the Journal of the American Medical Association, New England Journal of Medicine, and things like that. And this is one of the places that I go to find articles that have been published in the peer-reviewed literature on conditions, on anything. You can really ask it anything. I'm going to ask it a genetics question. What is Kabuki syndrome? And then it will take a moment. And then it tells you what is this condition, you know, and then it gives you references. None of these references are hallucinated, as can happen sometimes with AI. All of these are indexed in PubMed or the National Library of Medicine. And then you can go directly to the source. So it basically pulls up literature on it that you can directly go to into PubMed, which is also an NIH-related resource. So you can go, if I click on this, it will take me to the actual PubMed article that I can read myself. Did it actually switch over when I did that? Okay. And then I can read about it. Currently, I believe that is only open to healthcare professionals at the moment and is not open to the community. I think you have to sign up. It is free, but you have to sign up and actually have a national provider number. But for those of you who are thinking about going into a healthcare profession and might be entering a healthcare profession in the next year, just keep that in the back of your mind as this is something that may be available, an AI tool which has been heavily vetted for medical accuracy and isn't just, a generative AI where you don't know where that information is coming from. Okay, so I've taken up about a half hour of our time. And I know I've wandered a bit, but I'm happy to take questions.
Don't see any questions right now, but I think that I'd like to hear a little bit more about kind of your journey from Emory to the institution you're at now and kind of what that looked like for your professional life.
Yeah, that's a great question. So as I mentioned before, because I'm doing clinical genetics, when I was looking for my first job, which was back in 2003, as I mentioned, I was only looking at academic positions and there were only 3 open in the country at the time. That is not the case now. And I chose to go to Emory because it was the place that I felt like I fit best in terms of my interests. And then I'm actually from the West Coast. I have a lot of family out here, and I did enjoy living on the East Coast, but I felt like I was far away from family. And I really wanted to come back to the West Coast. I think a lot of people do have regional preferences for a variety of different reasons, frequently related to where family is located. And so I really wanted to target the West Coast, the Pacific Northwest. I'm from Oregon originally. And so I was waiting for a job to open up in this region. So this is part of the downside of going into academic medicine is that sometimes there isn't a job opening in your field, in your region, and you have to wait for that to happen. I came to the University of Washington partly because of their genetics expertise. So they actually also were instrumental in inventing some of the new genetic testing technologies, which now have gone into genome sequencing, full genome sequencing. So they were the first group to actually be able to set up that in a clinical setting of anywhere in the country. So really at the forefront of genetic technologies that could be brought into the clinic. So that's why I ended up wanting to come here over other places. So good question. It said, do I know when open evidence would be released to the public, or if there are other LLMs that could help find evidence for papers in medicine? So right now, so I don't know whether when or if open evidence is going to be released to the public. I don't know. This is a relatively, probably been in existence for 2 years, maybe. And they are not a publicly traded company or anything at this point. So I don't know when that's going to happen, when it's going to be rolled out differently. So usually where I go for literature searches, if again, open evidence I go to now, but for literature searches, I would go to the PubMed at the National Library of Medicine. That is freely available and open. The issue with looking up scientific articles is that some scientific published articles are open access, so anybody can read them. Some are not, and you have to have an institutional login or you have to buy the article. I would say most of the time, if you can find it on PubMed, frequently you can also find it on Google if you know what you're looking for. I don't necessarily do just a literature search from Google. I usually start out with PubMed or something like that, where I know I'm going to be getting peer-reviewed publications from reputable journals. But if you can't access an article off of PubMed, frequently you can somehow get it on Google or somewhere else. I would say that many scientific and medical journals are moving toward a more open access type of publication, where they're allowing anybody to be able to access that information. Okay, and then the next question, would you mind sharing more about your journey toward completing your subspecialty training? Yes, so I think that, you know, if you are someone who is going to medical school, one of the big dividers is, do you want to see adults or do you want to see kids? So that is true across the board. Even if you go into a surgical subspecialty, are you going to be doing adult urology or pediatric urology? You know, that kind of thing, adult oncology, pediatric oncology. I find that people have different tolerance levels. And that frequently you don't know what your tolerance level is until you're actually like doing a rotation in medical school and you're like, this rotation's driving me crazy. So for me, I really, when you're seeing adults, adults tend to, in general, have more complex or multiple problems. You know, they may have heart disease, diabetes, hypertension. They may have a lot of things going on. Adults can be very good at giving you a history and knowing what medications are on, and they can be very bad at that. Depending on where you're practicing and what your catchment area is, in adult medicine, I came across a lot of like, I'm taking this little blue pill. Do you know what that is? And I had a hard time with that, especially in the middle of the night when you're admitting someone and they're on 50 medications and they don't know what their medications are. Now, some of this is going to already have been addressed through the electronic health records. And so now I think that's less of an issue than when I was going through training and electronic health records were not as common. And so you really had to rely on people actually telling you what medications they were on. And there was no other record that you could access, especially in the middle of the night. So I think that's different. I think people have told me who have not gone into pediatrics that they had a very low tolerance for having to deal with the third party, which is usually a parent. Not always. I mean, we see plenty of people in pediatrics who are teenagers and they can handle their own health care to some extent or completely. Some people didn't like dealing with infants or toddlers who couldn't give you a history yourself. You have to kind of say, I think they're having pain. I think they're having this issue. I think they're having that issue. And they didn't like having to, again, deal with a parent. What I found is that generally parents are very good historians, because even though adults may not handle their healthcare the same way, usually they're very good at handling their child's healthcare. And they're very good at knowing what medications their child is on and making sure their child's getting medications and things like that. So oftentimes parents are going to be more on top of what's going on with their child than many adults are with their own healthcare for a variety of different reasons. And so I think for me, the first question was, do I want to do adult or pediatrics? And so I chose pediatrics because my tolerance level was much better. It does not bother me if people are like screaming or crying in a room. Other people, they couldn't stand that. I can't deal with the screaming and crying. So again, it depends on everybody's like tolerance level for these things. What bothers you, what doesn't bother you, what you can deal with, and what you can't deal with. Once I went into pediatrics, I actually did not think I was going to go into genetics. Again, I still was under the impression that, so every geneticist I had worked with who was an MD geneticist had a basic science research lab and would see patients 10 to 20% of their time and be in the lab the rest. And that was my impression of what genetics was. And I did not want to do that. So I actually was going to go into endocrinology, which has a lot of overlap with genetics because we have a lot of shared patients. So endocrinology is where you have hormonal issues. And in pediatric endocrinology, a lot of that is like short stature of unknown cause. So they're really short, you don't know why. So there's a lot of patients that we overlap with endocrinology and genetics. And so that was sort of an adjacent field that I'm like, oh, okay, I can maybe do that. Although I didn't love taking care of people with juvenile onset diabetes per se, because that can get a little bit monotonous if you're doing it all day, every day. Again, tolerance levels. Depends on your tolerance level. Some people love that. And what ended up happening is that the institution where I trained brought in a new head of clinical genetics who was an amazing, he still is, amazing clinical geneticist. And he found out that I had actually done some rotations in genetics as a medical student. And he actually contacted me proactively and asked me whether I would be willing to actually train with him in genetics. So it was a little bit of serendipity that I ended up in genetics. And I think people will find that there are mentors that you have in your journey through healthcare who will sway you in different ways that you don't realize until later. So it definitely was a bit of serendipity for me actually going into genetics, having an amazing mentor who was a clinical geneticist that showed me that this is a clinical field and that you don't have to be doing basic science research. And then I did a 2-year fellowship in medical genetics after I did pediatrics. And then I went and got a faculty position. But I think that kind of dovetails into the next question of what counts as research? Does PCR and electrophoresis count? Does research have to yield results or publications? Do research and shadowing and volunteering hours need to be recorded? So research can be a lot of different things. And so some types of research are going to be being in a lab and doing PCR and electrophoresis. I mean, that's what I did. What I did when I was before I went to medical school, when I was working in a basic science genetics lab, we were going into the clinic and, like I said, taking actual patient blood samples. My job was to extract DNA, do PCR, and do sequencing. And that's what I did for 3 years, trying to find genetic changes in a gene called FBN1 in people with Marfan syndrome. Because the gene had only recently been identified to cause Marfan syndrome, and then we were going through our patient population of people who were clinically diagnosed with Marfan syndrome and trying to find their genetic change. Fibrillin is a large gene with many exons. And so that's why the sequencing was very time intensive, and there was no clinical genetic testing lab that was doing it because it was too expensive. That, of course, has changed. Now we can easily do it, and the costs have come way down. And again, that was in part to the technologies that were invented here at the University of Washington for this. One of the reasons I came here. They invented some of these things that have allowed us to now be able to do this kind of testing for a reasonable price. What I do now in terms of research, I do all clinical research. What does that mean? What is clinical research? So again, it can be lots of different things. I already showed you, I've brought up Kabuki syndrome several times. It's a genetic condition that I have worked on for a while. Many rare genetic conditions, particularly ones that are typically diagnosed in early childhood or in infancy or even prenatally, have very robust parent and family support groups. I work closely with the Kabuki Syndrome Foundation, which is a parent run organization, and because of the mechanism of how Kabuki syndrome causes the issues that it causes, there is a question about whether, again, a drug could be repurposed to treat people with Kabuki syndrome. So one of the things that we had been working on is moving toward a potential clinical trial for a new study drug for people with Kabuki syndrome. So that counts as clinical research. So this is so we just are finishing up a 5-site clinical trial readiness study between Seattle Children's Hospital, Boston Children's Hospital, Johns Hopkins, Sick Kids in Toronto, and St. Jude in Tennessee, with all of our patients who have Kabuki syndrome, so around and different regions, looking at if you're going to do a clinical trial, you have to show that whatever your treatment is improves outcomes. How do you do that? You have to start off with saying, what's the baseline outcome? So this clinical trial readiness study is what's the baseline outcome for a bunch of different things, so that if you then use a study drug, you could show, does this actually improve those things? So that is clinical research. I also, like I said, I do research around the world. One of the things we're doing is studying whether the newer generation anti-inflammatory drugs, many of which you'll see advertised on TV, like, let's see, Skyrizi, or other drugs that are used for autoimmune conditions. We look at, so we, again, I work with the University of California, San Diego on an international study where I see babies who've been exposed to these medications prenatally, and I look for evidence that could it have caused any issue in them. These are post-marketing surveillance studies that are frequently mandated by the FDA when a new drug comes to be put on the market. So that's also clinical research. That's an epidemiologic study. The question is, do you have to get results and publish? I mean, hopefully, if you're going to do a study, you would have those outcomes. As a faculty member at the University of Washington, I am expected to publish. That's one of the things that happens if you're in academic medicine. You're expected to be involved in some type of research. Now, I don't actually go out and get grants. I find this the best of both worlds. Other people approach me and say, I need a clinical geneticist on this. I'm getting funding for blah. So the University of California, San Diego group actually approached me about working on their post-marketing surveillance study. The Kabuki Syndrome Foundation approached me about doing, being one of the clinical sites for this Kabuki syndrome study. So most of the time, I'm working with other groups and they're going out and getting funding, and then they're including me as part of the research study team. But as I mentioned, that's not, I still see patients 50% of the time. So I can only spend a certain amount of time on clinical research because I do enjoy seeing patients and I want to see patients in clinic. Some of those patients will turn into research participants, but I would say as a student, I don't know that anybody would expect that you would have a publication. If you were going to go into academic medicine as a career, then you absolutely would be anticipated to need publications. But for large studies, I'm not usually writing the publication either. I'm included. Now, I've written my own studies. I've done my own things. I've published lots as a first author, but for something like this multi-site clinical trial readiness study, I'm probably not going to be the one writing that up, but I will be listed as an author because I provided research data and analysis. And then I think the question, do research and shadowing and volunteer hours need to be reported? So research hours, not necessarily. Usually you can say, like, I worked on this research project and this was, what we did, and this is kind of how far we got. Again, some of these research projects might take years. And so if you're, a trainee or somebody who is in or thinking about going into a training program, you work on it for a year or two, you may not get all that far, and that's okay. You can say, I worked on it for this many months, or I worked on it for a year, or I worked on it for 2 years. For shadowing and volunteering hours, I think it's helpful to have a ballpark figure of like, you know, did you do 1 hour or you did 50 hours? You know, I don't think you have to say like I did 37.25 hours. I think people just want to know, was this a one-time thing, or you did this over a period of time with a number of different hours, and therefore you had a more robust experience. That's, I think, what programs, you know, pre-health programs where you're applying to you know, a nursing program, a genetic counseling program, a PhD, whatever, they want to see, I did something for a period of time and I actually got a pretty useful, you know, exposure to it. Let's see, and is there any advice for people considering going for an MD, PhD? Is it impossible to get into research as early as possible? So research, so it depends a little bit. So for MD, PhD, frequently they want to see that people have done research as an undergraduate or even post-bac before applying for an MD, PhD program. They want to see that you actually probably have a couple years of research. For an MD, PhD program, they may also be interested in you actually having a publication at least, so that you get an idea of what is it like to work in a lab. MD, PhD programs come in two flavors. The first one is actually the one that's the NIH, you know, funded program, which is that, so it's called the Medical Science Training Program, MSTP. Many medical schools, if they're going to be a research medical school, have a certain number of MSTP slots, which means that the federal government is going to pay for all of your training, including the medical school. So you come out with no debt. Those spots can be highly competitive. And the idea is that you will do that. You will take at least 8 years, right? You're going to do 4 years of medical school, and then your PhD is going to be 4, 5, 6 years, something like that. And then they are training you to be the next generation of physician scientist who's primarily going to be doing grant-supported basic science research. That's the idea. Now, they weren't going to hold you to that. Like if you did an MD, PhD and you didn't become a basic science researcher in a lab, they're not going to come back and ask you to repay them. But that's what they're looking for. People who are like, I want to be a basic science researcher and that's going to support myself with NIH grants. So that's what they're looking for. There are other, now you can do an MD, PhD without being part of the MSTP program. What that usually means is that you're going to be paying for at least a portion of your training. Those slots are less competitive, and then medical schools have variable numbers of those. You can also go to medical school and partway through say, I'd really like to also just stop out and do a PhD. You can do that. And it's not part of the medical program. It's a separate PhD program, and then you can come back to medical school. So there's a lot of different ways that you could do that. In terms of getting into research as early as possible, it depends a little bit on what resources are in your area. If you are next to an academic center or a university, even if it doesn't have a medical school, it's going to be a lot easier to get involved in research. I guess what I'll say is, I think it's challenging for high school students to be involved in basic science research unless you are in a town where there is a university and you have some connection into that university, where you might know people that can help you get into a lab. I would say that most universities don't take high school students into their labs outside of summer internship programs or really specific types of programs that are specifically for high school students that usually are running through the summer. There are places that have that. I know the University of Washington has a summer internship program where you can be in a lab. And so I think there are places like that. I think as an undergraduate student, if you are at a research university, it's much easier to get into doing research than if you are at a smaller college that doesn't have a large number of research faculty. But I think that anyone who's an undergrad can probably get involved in some kind of research through their university, and the university usually has an office of undergraduate research or something like that that you can go to and find out what research opportunities are available to you. You can also do, once you have a degree, you can also do post-baccalaureate research. I would say that the funding climate for research right now is unknown. A lot of research is being cut, grants are being cut. I think that right now many researchers have limited funds and are not as likely to want to take a student for who's, they have to pay. So if you have a possibility of being able to take research for credit, sometimes people are like, that's great because I'm not paying you and I have limited resources in my lab. So you could also explore, if you are currently a student, whether you could do research for credit. Because I think that researchers are sometimes more open to that, especially if they have limited funding opportunities. Okay, so as someone who's interested in pursuing a career in genetics, what are the most rewarding parts of your career? Do you have any recommendations in terms of classes, programs to find what medical specialty you want to do? How did you decide that you were ready for medical school to become a geneticist over becoming a genetic counselor? So that's a great question. I think, so first of all, the most rewarding part of my my career is being able to help families understand why their family member has whatever is going on with them, and understand what that might look like, provide resources and treatment for them. I would say, again, for many genetic conditions, the treatment is supportive, but for many families, understanding why for me, it would be child, because I work in pediatrics. That's not always the case. Clearly, there are many genetic conditions that affect adults and don't necessarily affect children. But from my personal experience, helping families understand, why does my child have this issue? Oftentimes being able to provide a specific diagnosis opens a whole door of possibilities for them, including being able to connect with other families who have a child with the same condition, and being part of a community, a parent support group, or other organization can be so helpful for families. So I think for me, it's really the families, being able to provide information to families and help them understand what's going on with their child and why are they having these issues. In the field of genetics, you sometimes do encounter people who are concerned about, is this my fault? Again, nothing in genetics is anybody's fault. So sometimes even just relieving that, like, I thought it was my fault because I did this during pregnancy and it caused my child to have this problem. Being able to relieve that guilt off of parents can be also very rewarding, of parents being like, now I understand this wasn't my fault. And then in terms of finding what medical specialty you want to do, I think that's challenging. I think that is, if you were thinking about going to any kind of training program, nursing or medical school or something like that, really you're going to do rotations through multiple specialties before you're asked to pick one. So for medical school, you usually go through at least 18 months to 2 years of rotations, and you are required to go through adult medicine, surgery, pediatrics, and then all sorts of other subspecialty things, so that you get an idea, because I think it's really hard to know what you might want to do until you actually have some experience doing it. And then you're like, man, I hate this. Or man, this is great, and I didn't think I was going to be great. So I'm not sure that so I think once you get into a training program, they're going to help you figure out what you want to do. That's the same in nursing. I believe, you're going to go through and you're going to have different experiences. Are you a surgical nurse? Are you an ICU nurse? Are you a floor nurse? Are you an ER nurse? You're going to get to rotate through that and see what kind of works for me. I think that this is not as true in medicine. So I'm a clinical geneticist. If all of a sudden I wanted to become an endocrinologist, that would be really hard to do. If you are a nurse and you are in one field of nursing, it's not that difficult to switch into another field of nursing, just to let you know. So once you've picked a specialty in medicine as a physician, people do change. I mean, I know people who switched residencies or did 2 different residencies, but once you get into your career, switching mid-career in medicine is not something that's done frequently. And oftentimes, if you're trying to do that, people are like, is there something going on? Like, why are you switching out of what you've been doing for the last 10 years? But there'll be ample opportunity to explore that. And I do know people who switched residencies because they got into their residency and they really didn't like it and they decided they wanted to do something else. So switching at a residency phase is something that can happen. It's just once you get into a career, it's hard to switch if you're going in as a physician. In terms of medical school versus genetic counselor, I think it depends. So I was really interested in being the person who was doing management of patients. As a genetic counselor, you really don't do patient management. You really do counseling. And so people who really love the counseling aspect of genetics, I think genetic counseling is great because what you do is counseling. You're working with families, you're helping them kind of cope with what's going on, you're providing them with resources, you're, again, really spending a lot of time with families, exploring feelings and, things like that. A medical geneticist does some of that, but not most, but mostly we're saying, I'm going to, take a medical history, I'm going to do a physical exam, I'm going to figure out what this patient has, and then I'm going to do the treatment. That's what you do as a medical geneticist. As a genetic counselor, it's usually I'm taking a really specific family history. Patient already has a known genetic condition. I'm going to then go through and figure out, is this something that is inherited? Do we need to test other family members? How do I provide resources to the family? So you're not actually providing a diagnosis. You're really doing let's help you now go on to the next level of maybe there are other at-risk family members that need to be tested, and how do we go about doing that? And, would they be interested? We do have families who don't want you to disclose. I mean, we cannot by law disclose protected health information to, you can obviously do that to legal guardians and parents of a child, but you can't do it to aunts and uncles, grandparents, can't do it to somebody who's not a legal guardian. And so working with families with a, my child has this issue, but I don't want other family members to know about it, but they're at risk for this. So how do we deal with getting them tested without, kind of letting them know what's going on? There's complex issues that can happen there. So the genetic counselor training, again, is a much shorter training program. So it's 2 years master degree. And during that time, you're actually out in clinics for part of that time. You're deployed into genetics clinics and you're working with geneticists as part of that training program. Whereas if you're thinking about a medical school route, you're talking about these 4 years of medical school. I did 5 because I did research during medical school, 4 years of medical school. And then depending on, if you wanted to do genetics, you could go into a combined program of pediatrics and medical genetics, or adult and medical genetics, or OB and medical genetics. Medical genetics is not a standalone field. You have to do it in conjunction with another primary care field. And the training is usually 4 or 5 years residency, depending on how you do it. I did full pediatric residency and then 2 years of genetics. They also have combined programs where you're doing kind of both, and then you do it in 4 years. Anyway, lots of different things. Okay. I'm currently a postbac program at UC Davis. Please let me know if y'all have any questions about that route. Oh, good. Okay, perfect. That's you. Sorry. What can first-year college students do to prepare for med school and MD, PhD program? When does extracurriculars become important? So again, if you are a first-year college student and you're thinking about an MD, PhD program, the best thing you can do right now is see if there's any way you can get involved in research of any kind. So that is going to be the #1 extracurricular that you are probably going to need to have. And again, I know it sounds weird to say it's an extracurricular, but it's not, going to be part of the your required degree probably to do research. So if you're interested in an MD PhD program, you need to get involved in some kind of research as soon as possible. If you can show that you've been involved in research for 2 or 3 years, that's going to look really good to an MD PhD program. In terms of other extracurriculars, things that are important, especially if you're thinking about going into anything where there's going to be direct patient care, is they want to see that you've done some sort of either shadowing with a healthcare provider or volunteer work or both. So that's the other thing, is you need to show that you actually have been in a clinical setting and have seen what people are doing so that you have an idea. You can say, yes, I shadowed this person for 2 or 3 months and I went to these clinics and I saw what they did in clinic and I'm still interested in doing it. So those two things, again, extracurricular. So shadowing, volunteering at, in a healthcare setting, and research are going to be the ones that you want to do, and you want to start looking at that now, especially the research part if you're MD, PhD. Let's see. Oh, have you worked with physician assistants with pediatric genetics? Is their role more aligned with counseling, and what role would they possibly have? So that is a great question. You know, I think right now, genetics has not addressed the use of physician assistants and nurse practitioners in the way that I would do it, because so currently where I work, we have 3 nurse practitioners who work with us. One of them has more training in genetics. There is no formal training program in genetics for a physician assistant or nurse practitioner, and I think there should be. That's what I'm saying. I think there should be. One of the nurse practitioners we work for basically worked for about 5 years with a different clinical geneticist, and sort of ended up getting the equivalent of genetics training that way, but that is not, there's no formalized training in genetics for a nurse practitioner or a physician assistant. So the nurse practitioners that we have, that we work with, primarily are involved in management of patients with genetic conditions where there are standard health supervision guidelines that have been published. So for example, Down syndrome. The American Academy of Pediatrics has published health supervision guidelines of how do you monitor and, you know, kids with Down syndrome. And, you know, our nurse, or for like neurofibromatosis, there are also guidelines for how you manage those patients. And so our nurse practitioners are doing a lot of that, of, you know, management of patients that have known genetic conditions, but most of their training is kind of on the job. Again, I hope that that changes. And I think the American College of Medical Genetics is sort of exploring, like, we need to be training some of these people more specifically in genetics and not just having them come into clinic and shadow us for a while and get on the job training. But I think, and then if it is a physician assistant or a nurse practitioner, they're not going to be doing genetic counseling the same way. Again, that we have even the nurse practitioners that and that we work with have a genetic counselor deployed with them. So the counseling is really going to be done by a genetic counselor. I mean, we do some of it. Like if I had to, I could do genetic counseling, but it's, you know, because we get some training as a clinical geneticist in that, but the real issue is you're going to be working with a counselor for the most of the time. How do you manage your work-life balance? That is a great question. For me, I have to compartmentalize a little bit. So I do have 3 children. They are now, one's in grad school and 2 are in college. So, you know, I raised 3 children. What I did is I made sure that when I was at work, I was at work. And when I was at home, I was not doing work. I really tried to do that. Now that you can't always do that because you are going to be on call some of the time, and sometimes you have to work nights and weekends when you're on call. But that was a more restricted, you know, like I knew that was going to be happening. But I really, I would come in the morning, you know, drop the kids off at school, come in the morning. I would work all day. I would make sure I was home for dinner, have a, you know, family dinner, family time at night, and then go back into work. So that worked for me. It's also a little bit easier because although it sounds like academic medicine is hard in some ways, it really probably affords you more time than if you were working in private practice. Because I work with a larger group, and so currently I only take 3 weeks of call a year. You know, I have colleagues who take 6 months of call because there's only 2 of them, you know, things like that. So, so I really tried to make sure that when I was at home, I was at home. Again, as much as I could. That's not always possible, but for the most part. I have a very helpful partner too, who, you know, was able to do, you know, help out with childcare and stuff as well. So, you know, there's a little bit of tag teaming there, but I think we made it work. Let's see. Will the amount of time that I've done an activity be asked in the application form or interview? So on the application, yes. I mean, it depends. So I can only tell you about medical school applications. I really don't know as much about like nursing applications or genetic counseling school applications because I didn't go through those routes. And I've been on the admissions committee for, you know, medical school residency and that, so I can really only answer that. So for medical school applications, yes, the application will ask you like how much time you actually spent doing this. I think that that's much less likely to be asked specifically in an interview, depending. So some people do interviews cold, meaning they haven't looked at your application. I think that's the more lazy way to do it. Theoretically, if you're getting an interview, they've read your application, they have some idea of how much time you've spent. They may ask you generally, like, did you do research? How much time did you do that? And it would be like, I did it for 6 months or I did it for 2 years. So they wouldn't be asking you like real specifics. Most of the time in an interview, they really want to know more about your thought processes and kind of what experiences you've had. Like, can you describe different experiences to me? How would you handle a situation like this? So they're less kind of fact finding because your application is going to have all of the kind of fact finding like a CV or a resume has on it. Okay. Do you do any collaborating with embryologists and or reproductive endocrinologists seeking to help folks have children? So to some extent, I don't, I have worked with embryologists primarily in studying, again, the impact of exposures during pregnancy on postnatal outcomes. So that's what we call teratology. Teratology actually does fall under the umbrella of genetics, even though it's not technically a genetic condition, although we do postulate that people probably have genetic susceptibilities because when an embryo has an exposure during pregnancy, they don't all have the same outcomes. Some have nothing and some have birth defects. Why is that? It's probably their underlying genetics that impact that, but it's not considered a single gene disorder. Reproductive endocrinologist. So I do work, so I don't work directly with reproductive endocrinologists per se. I do get referrals from reproductive endocrinologists. Oftentimes we're helping advise them about like, this child has this genetic condition. The family is interested in doing pre-implantation genetic testing for this. Here's the information you need to know to help this family do that. Most reproductive endocrinologists are actually people who are trained in you know, maternal fetal medicine, OB. Many of them have genetic counselors that they work with that then if something gets really complicated, a genetic counselor can then call upon a medical geneticist. One of our former genetics trainees, who is an obstetrician, is now doing a fellowship in reproductive endocrinology. So some reproductive endocrinologists also are double boarded and trained in genetics. So I work more with our maternal fetal medicine specialists because I do see people in prenatal clinic when there is a diagnosis, a prenatal diagnosis, and family is interested in what does this really mean postnatally. Genetic counselor can give information about that to some extent of like, this is generally what you would see. My role is Let me tell you, as a clinical geneticist, this is typically what we would do for a child with this condition over time. Here's what the management would look like. Here's what outcomes look like. Because I've seen a lot of patients with this condition, I can give you my personal experience. So we add a kind of a different component to that, which is more like this is what it's going to look like postnatally. For the most part, I would say most of the people I meet in a prenatal setting in my current work are people who have decided to continue a pregnancy and want the kind of continuity of care from the prenatal to postnatal. Like this, your baby's going to be born. This is what we're going to do after birth. We have a plan so that when they're born, people aren't like, well, what's the plan? We make up a prenatal, like a postnatal plan for when you deliver. This is what's going to happen, and this is what we're going to do. And now we have a plan. Let's see, is research just for shadowing you were involved in and is capable of doing research? Okay. Oh, sorry, I read that wrong. Is research just for showing you are involved in and capable of doing research? If so, then the type or topic of research shouldn't matter, or is it better to do research related to the human body? That is a great question. I think it kind of, again, it depends on what your goals are. I think that if you are someone who is interested in going to medical school, and primarily if you're interested in being a physician who is working in a private practice setting and possibly, in a more rural area, no one's going to say you have to have done research. I would say that if you're interested in going into an MD PhD program, you absolutely have to do research. And then if you aren't sure what you want to do, but you're thinking you might want to do, maybe you haven't ruled out going into academic medicine or going into a subspecialty of medicine, then I think doing research could be helpful in you understanding whether this is something you actually would be interested in doing. So I wouldn't do research just for the sake of doing research. I would do research for, I know I definitely want to go into an academic field or get an MD PhD, or I haven't ruled that out and I really want to find out what research is about and get some experience so that when I get into medical school and I'm deciding what I want to do, I kind of know whether research is something I love or hate, because that's going to play into what you decide to do in the field of medicine. So I would only do research if you think this is something that you're really interested in or it's going to help you make decisions later on. You do not have to do research to apply to medical school. I think that doing research is looked upon favorably by medical schools, but it also depends on what medical schools you're looking at. And I think DO schools are not necessarily as, I wouldn't say interested, because I think everybody's interested in whatever it is you did. I think that the DO schools are going to not care as much whether you did research or not, because I think also their philosophy of medicine is a little bit different. I mean, we all do the same thing. And I think people pick an MD program versus a DO program for a variety of different reasons. So I think it really depends on kind of what your goal is. If you're going into a different profession like nursing or something like that, I don't know that research is needed at all. And although I will tell you, I do know a number of nurses who have gone into research. They become a nurse researcher for, clinical studies, clinical trials, things like that. So it's not that you can't be involved in research if you go into nursing, but I don't know that nursing programs, again, are going to be as concerned about, like, did you do research as part of your, preparation to go into a nursing program. And then I don't think, so if you are, I don't know that you actually have to do research that's directly related to the human body. I think that it's really helps people understand, do I like research or not? And I think medical schools that are looking at research experience want to see, that you have some skills in general research. Like, you understand what it means to make up a research question. You understand how do you design some methodologies to answer that question? How do you collect data? I don't think they care if it's specifically related to humans or not. I mean, I know people that did research in plants, ecology, different things like that. So I think it's really just you understanding the process of how research works in general is kind of what they might be looking for if you were, again, going into something where you think research might be a part of your career.
I think we've run out of questions. I had a quick question for you. Or I guess I have two quick questions for you. One of which is, do you think you could run through, I know you talked about a little bit about the plan. Do you think you could run through like what's a typical case for you on a weekly basis or a monthly basis?
Oh boy. I'm not sure there is a typical case. We deal primarily in rare genetic conditions where I might see one patient with it a year. But there are some more common conditions. Again, we do a little bit of management for Down syndrome, but not a lot. I mean, Down syndrome is one of the most common genetic conditions, but that, is so common that I think geneticists don't necessarily have to be heavily involved in the management of those patients. We're more involved in management of patients where people don't really are like, I as a primary care provider, I've maybe seen one patient with this ever. Whereas, we're seeing patients with it, even though I might only see one patient a year. Now that I've been working for 20 years, I've seen at least 20 patients with that. Again, which doesn't sound like a lot, but when you're talking about 200 people reported in the entire world with this condition, 20 patients is a fair number. So again, we deal in the ultra rare. To give you an example, so there is a condition called Williams syndrome, which some of you may have heard of because it is a more common, it's a chromosomal deletion on chromosome 7. People with that can have heart issues. The other thing they can have is that their blood calcium levels can be too high. And you might think like, is that bad? And it turns out like, yeah, it kind of is bad. That causes symptoms if it's really too high. One of the things it can cause is, your kidneys filter all your blood, right? And if you have too much calcium in your blood, it can get deposited in your kidneys and you can get something called nephrocalcinosis and that can impair your kidney function. So that's also bad. But you can also have symptoms from too much calcium, like that are not good symptoms to have. So one of the things that we do is because most primary care providers don't have a patient with Williams syndrome, we usually see them once a year. We make sure that we're taking care of all their issues related to Williams syndrome. So one of them is, I will say, okay, we got to get your calcium, serum calcium level. We got to do urine study to make sure you're not spilling too much calcium into your urine. We need to get a kidney ultrasound to make sure you're not getting nephrocalcinosis. And oh, by the way, did you happen to know that every pediatric multivitamin has calcium and vitamin D in it? Vitamin D helps you absorb calcium, and therefore anybody with Williams syndrome should never be on a multivitamin of any kind. So that's the kind of advice we give, where you're like, look, everybody thinks vitamins are fine, right? Well, not for you, because we happen to know everything about Williams syndrome. Those are the kinds of things that management issues that we take care of, things that other providers may not be aware of, that we say, we'll take on the management of these issues because we know how to deal with them and treat them and counsel families about it.
All right, awesome. And then one more question in the chat is, does research have to be designed by myself or can I just follow an established lab?
Most of the time you were going to follow an established lab. So it would be very unlikely for someone who doesn't already have training as a PhD or something like that to be able to design your own research program. So most of the time you're saying, I joined a research lab, I worked on this project, these are the components I did, this is what I learned from it. They want to see that you understand the general concept of what was going on in the lab, but no one's going to expect that you designed it yourself or that you went out and got funding for it or anything like that. They're going to say, yeah, you worked in a lab with a group of people who mentored you and helped you through, and they gave you a component of the project to complete with their supervision. What would an average week look like for you? So an average week is, I would see, again, because genetics is complicated, And oftentimes we have a lot of different recommendations. So today, before this, I saw a patient who has something called tetrasomia 18p, so has 4 copies of the short arm of chromosome 18. So for that patient, we needed to do a more thorough evaluation. So I had like 12 recommendations for that patient of things they needed to get done as part of their initial evaluation. So that takes a while, right? You got to explain, here's what's going on. Here's the things we're worried about. These are the things we need to check up on. These are one-time evaluations. These are things we're going to be monitoring over time. What are recurrence risks? Is this something that was inherited, not inherited, blah, blah, blah. What happens if you want to have another kid, and what's your recurrence risk, and how would we test for it? So we usually generally spend at least an hour with every patient. So a typical week for me would be a full day of clinic on Monday, which is 6 patients. So I see 6 patients on Monday. They can have a variety of different things. Tuesday, I go to the gene reviews office. I do medical editing all day and run gene reviews. Every other Wednesday, I do a multidisciplinary clinic, which is called our Differences of Sex Development Clinic. So these are people who are born and they have abnormalities that involve their gonads, which are ovaries/testes, and their internal and external genitalia. And I work with 5 other providers in that clinic because it's multidisciplinary. I'm the geneticist. I try and figure out, like, why did this happen? We work with endocrinologist who does all the hormones. We work with a adolescent gynecologist who sees our individuals who are being raised female or are female. I work with a pediatric urologist who primarily sees those individuals being raised male, but may also see some of the females. And then a psychologist. And of course, we have a genetic counselor because I always have a counselor with me. So I will see 6 patients in that clinic, but we do a multidisciplinary. We go in and we do a combined history and physical with all of us in the room at the same time so that you only have to go through it once, and then we make a combined plan. These can be very complex patients involving multiple systems, and so we try and figure out how best to treat these individuals to keep them healthy. There can be life-threatening conditions hidden within this umbrella of differences of sex development. There can also be cancer predisposition syndromes, things like that. So my role is to really say, can we figure out what's going on, and does that help us understand whether this person is at risk for life-threatening conditions and or needs tumor surveillance? So that's every other Wednesday. I go out and do an outreach clinic about once a month out to Eastern Washington. We have a clinic out there with embedded genetic counselors in that area so that we can provide that. And then, so I do that. If I'm going to do that, I do that once a month on Thursday. We also do consults only in the neonatal intensive care unit at a private hospital in downtown Seattle that I'll do on other Thursdays because they don't have a geneticist. So we'll only go and see NICU consults there on Thursdays. And then I do for my research. So I was seeing research patients as part of the clinical trial readiness study. I was seeing about 1 a week. And then I do a half day of clinic a month for the other autoimmune diseases and pregnancy study for UCSD, where I see, because that's only a physical exam, we're not actually providing medical care. It's a research study. I'll see 8 patients in a half day. And then I have various meetings. So we have research meetings and editor meetings and division meetings, and I'm on the faculty senate, and I was on the promotions committee. So there's other committee things that I have to do. I also write questions for the National Board of Medical Examiners. So I do that also. Like, these are things that you're expected to do as part of your academic appointment, and you fit them in where you can. So like, when I'm not seeing patients or doing research, I'm doing these other things. And it can vary. So I have to write 40 questions a year for the national board most of the time. So that's during the fall. And then we have meetings in the spring, and then we review all the questions and we rewrite all the questions. And, so that's kind of going on all the time. And then, I give lectures to the genetics fellows. We do have trainees in most of our clinics. I used to give lectures to medical students. I used to give lectures to pediatric residents, but because I'm a more senior faculty member, a lot of those responsibilities now go to the junior faculty who need those teaching evaluations. I did teach a class in the genetic counseling program, which I also passed on to a junior faculty member who needed that for promotion purposes. So there's teaching that's kind of going on dynamically. Yeah, so that's kind of my average week of doing lots of different stuff. That's what I like about academic medicine, is you're doing lots of different stuff all the time. So you're always doing something different. That's also what I love about genetics, because when I was a genetics resident or fellow, they call it's actually technically a second residency, but when I was doing I saw a patient with my mentor, the person who actually convinced me to go into genetics, who was the division chief of clinical genetics. He just retired. He actually then became chairman of pediatrics in South Dakota. But I saw a patient, and I'm pretty green. I haven't seen a lot of patients. I saw a patient and I'm like, I don't know what this patient has. I've never seen anything like this. She had amazingly symmetric, weird overgrowth of like her supraorbital ridges and other parts of her body, like these 2 digits on each hand. I mean, it was a very weird overgrowth syndrome. And he came in, it was our division chief, so he'd been doing it for over 20 years. And he came in, when we walked out, he's like, I've never seen anything like that either. So we actually sent that patient to the NIH to see their overgrowth specialist. And he said, I've never seen anything like this. We ended up writing it up as a case report. We still don't know what she has. I mean, she's still being followed by the original institution where I saw her, and she's now in her 20s. They still don't know what she has. So I love that. Oh, and then I was going to mention, as part of my academic research also, like I'm involved in planning a scientific meeting that's happening next year. I plan that meeting every 5 years. So yeah, there's a lot of just different, like you're doing different stuff all the time. And that's what's fun for me. Other people may hate that, but that's what I like doing. What was the hardest part of your journey to this career? Hands down, pediatric residency. It is not like that anymore. So we did not have the 80-hour work week. You can't go over 80 hours a week. They now have duty hour cutoffs for residents. They did not have that when I was in residency. So we would do 36-hour shifts every fortnight. But also the days that you weren't doing that, you were just working all day. So we did 36-hour shifts every fortnight, and we got 4 days off a month. And we did that for 3 years. So people sometimes ask me, did you ever think about quitting? And I'm like, I think that every single person I knew seriously considered quitting. Like, I think that there wasn't anyone who didn't consider quitting. Like, I think that was normal, because it was very, very intense. Again, it is not run that way anymore, because it was not good. It was bad. So that was the hardest part.
Wow, that is wild to hear. And thank you so much for sharing about your journey thus far and answering all the questions. I feel like folks learned a lot, and hopefully everyone got all their questions answered. If not, please let us know and we can coordinate with Dr. Adam to see if we can get any other questions answered about maybe genetic counseling or any research opportunities and things like that. I am going to share my screen and jump into a little bit of wrap-up information for us. All right. So we would love to hear some of your insights from today's session on LinkedIn. LinkedIn is a professional social media platform where you can expand your network. So if you have any insights that you'd like to share with your network and start creating your network, please tag pre-health shadowing. That way we can see what y'all are thinking, and also so you can invite other people who are in your network to pre-health shadowing. Again, as we talked about at the beginning of the session, if you're interested in volunteering, please let us know. You can send us an email, poke around the website, see if anything tickles your fancy. Also, if you can donate, we would really appreciate it, whether that's financially or donating your time or sending this QR code to anyone in your network. That would also be greatly appreciated. All right, moving into our wrap-up information. In order to get a digital certificate for attending this session, you need to take the post-session quiz, which will be available on the website. So it's a 10-question multiple choice quiz based on the presentation, and you do have to pass with a 70% or higher to get verification. So please let us know if you have any issues accessing it. We'd be more than happy to walk you through how to get access to the quiz. Please do not worry if you missed any part of the session today or if you had any technical difficulties. We will have this entire session uploaded on our YouTube channel, as well as any of our past sessions. So if any other people have presented that you'd like to check out, please look at our YouTube. They've been great. And Dr. Adam, we are so, so grateful to have you in our YouTube family now. You'll be there forever. So if you ever want to go watch yourself or send anyone the link, it'll be right there for you. All right, our next session is currently scheduled for November 4th. So be sure to catch our sessions every week. And if you have any questions, feel free to hang back and let us know. Again, Dr. Adam, thank you so much for sharing all the tidbits, especially the information about some other specialties and opportunities. That's really invaluable, especially if folks don't really know exactly what they want to go into, to hear that there are other things that you can do. I had personally never heard of genetic counseling before. And it's nice that they also collaborate like so much together. So you have the opportunity to learn from other people in your field. That sounds great. So thank you so much.
Thank you.